Welcome to this first of our 3 virtual events being hosted by the BMA's Board of Science. As you know, we have these events every year around the annual representative meeting of the BMA, and these are the 2-1 Victor Horsley lectures. Just 1 or 2 things about how we're going to do the programme. You're all probably now used to submitting questions live, and you'll find there's a box on the right, a Q&A box. So we would love you to ask questions. I know some of you have pre-submitted them, and we'll ask some of those as well. And if you like a question that's already been put up, please put a thumbs up symbol, because the more popular ones will obviously be selected to be asked. So Victor Horsley, who these lectures are named after, was a British scientist and a professor. He was a pioneer of neurological surgery and played a pivotal role in the shaping of the standard of neurological practice. He also, I mean, obviously a man of many parts, played a role, he and his team, on the treatment of mixed edema, and also something as different as eradication of rabies in England. Professor Horsley was known for his kindness, his humility and generosity to patients and his colleagues. He also supported suffrage of women, medical reform, and free healthcare for the working class. Sadly, he died in the First World War, which in fact he was perhaps too old to have gone to, but he set himself forward, and in fact he died of heat stroke. So we're very, honoured really to have him named on these lectures. He was knighted for his services to medicine. So today I have the enormous pleasure of welcoming Professor Sadaf Farooqi. Now, Professor Farooqi is the Wellcome Principal Research Fellow. She's a Professor of Metabolism and Medicine at the University of Cambridge. She's an internationally leading clinical scientist who's made seminal contributions to the understanding of genetics and the physiological mechanisms that underlie obesity and its complications. What Sadaf has done is actually fundamentally alter the understanding of how body weight is regulated. And she, along with her colleagues, discovered and characterized the first genetic disorders that cause severe childhood obesity. She's also established that the principal driver of obesity in these conditions was a failure of the control of appetite. Now, we all talk about research going from the bench to the patients, and I think Sadaf's work is often cited as an exemplar of how translation of research into mechanisms of disease and leading to patient benefit has happened. So congratulations on that. Clearly a woman of her eminence, has received several awards, and she was awarded the highest honour from the UK Society of Endocrinology. But can we just congratulate her, as this year she was elected as Fellow of the Royal Society, which of course is the pinnacle, I think, Sadaf, of your recognition of your exceptional contributions to science. So well done and congratulations. So it's a great pleasure for me to ask Professor Farooqi to give her Victor Horsley Lecture 2021 on obesity, causes and consequences. Over to you, Sadaf.
Thank you very much for a very kind and generous introduction, Parveen. It's my great honour to be talking to you today, and particularly my great honour to be introduced by Professor Parveen Kumar, who I've really been looking up to since I was a medical student and, of course, read the famous textbook of medicine. So it's a real honour to be introduced by you today and to share with you some of the work that we've been doing to try to understand an important clinical problem. So this is just a picture of our Institute of Metabolic Science at the University of Cambridge, where I work. And really our focus has been trying to improve the situation for our patients with obesity, which, as you know, is a major issue, but for which actually we have pretty limited understanding and where we actually have very few options for our patients. So the things that we've been interested in trying to do is to try to understand, why do some people gain weight more easily than others? Can we understand why some people develop obesity-related complications whilst others may not? And ultimately, of course, can we find better ways to prevent and treat obesity? Now, of course, you were very familiar with the problems that we face in terms of the number of people who are affected by obesity. And obesity is really defined as an excess of body fat that adversely affects health. And we use a BMI criteria of a BMI more than 30 to define obesity. And using that criteria, at least 20 to 25% of the UK population are clinically obese and 50% are overweight or obese. So it's a huge issue across our population. Now, if we look at the illustration on the right, of course, we see the clinical problems that go hand in hand with obesity, with which you'll be very familiar. Of course, type 2 diabetes, hypertension and cardiovascular disease, sleep apnea, fatty liver disease, and several forms of cancer are much more common in obese people. But I think the really important thing to bear in mind is, alongside the sort of public health concerns, which are substantial, is the impact of obesity on the individual. So not only on the medical conditions, but also on the emotional health of the individual. Depression, psychiatric disorders are more common in obese people, but also the impact of stigma and on life chances. Now, what we do know is that people with severe obesity, that's with a BMI of 40 or above, have the highest burden of complications. And some figures are shown there with the rise in diabetes, even just per every 5 BMI units. And as I mentioned, the impact is huge on people's lives, their employment, their educational opportunities, particularly in children with severe obesity. And there's a widespread stigma in society towards obese people. Now, what we do know is that if we can help people to lose weight, even just 5% of their baseline weight, irrespective of what that weight is, results in substantial clinical benefits on their metabolic and cardiovascular outcomes. And really, the strong data from the Diabetes Prevention Program show that if we can achieve 10% weight loss, then you substantially reduce the risk of type 2 diabetes in somebody who's obese. So really our interest has been trying to understand the fundamental mechanisms and control weight to see if we can find more effective ways to prevent and treat obesity, particularly severe obesity. Now, why do some people develop severe obesity? And what's interesting is we tend to think about this as a modern problem, but in fact there have always been some individuals throughout history who were severely obese, and really around the world, as these photographs show here. Indeed, even Hippocrates talked about obesity. He talked about corpulency and actually being a harbinger of other conditions. He talked about fertility. He talked about sleep apnea. So it was well recognized even in ancient Greece that obesity caused other clinical problems. Of course, what is happening now is we have a much higher number of people with severe obesity. What is causing that? Well, clearly it's been driven by changes in our environment, in the amount of food we eat, the type of food we eat, and the fact that we undertake less activity. All of that tips the energy balance equation. So on average, we eat more than we expend, and that's why people are gaining weight. But actually within a given environment, there's a lot of variation in how much weight people gain. Some people gain a lot of weight, develop severe obesity. Some people actually remain slim in the same environment. And what I'm going to show you is how we now understand that it's genes that influence where you lie on that spectrum. Now, the evidence comes from a number of sources. So, often when we look at genetic factors for any trait or disease, some of the strongest evidence comes from studying twins. So if you study identical twins who are separated at birth and reared apart, they have a 90% identical body weight as adults. If you look at children who are adopted, they tend to share a body weight that's similar to their biological parents, as opposed to the adoptive parents with whom they shared the childhood environment. And a very elegant study was done by colleagues in Canada, where they studied young adult identical male twins. They actually kept them in a research study for a year, and they overfed everybody. And obviously everybody gained weight, but the amount of weight they gained was very similar between two members of a twin pair, and quite different across sets of twins. So essentially our genes influence our response to the environment. And we can demonstrate that very clearly. How much do they do that? Well, actually, it's 40 to 70%. And what that really means is if you take any two people, the variation in their weight, 40 to 70% of that variation is down to variation in our genes. So, oops, on to the next slide. let's try this now. Okay, so this is just a little bit of an illustration of how we think about the genetic factors that affect weight. So on the left-hand image, you can see the identical twins, and on the right-hand image, the non-identical or the dizygotic twins, and you can see that the identical twins are very similar in terms of weight, fat mass, and fat distribution, as opposed to the non-identical twins. This happens even in studies that have been done quite recently in London, for example, showing a high heritability in children, and the effect of genes is much greater than we think, and more so than that of the shared childhood environment. Now, how do these genes work? What do they actually affect? And what they really affect appears to be appetite and weight. Sorry, my slides are not advancing quite in the way they should. Okay, if we do next slide, Steve. Is that genes affect the amount of food we eat, but also how full we feel after a given meal. Our genes affect our basal metabolic rate, and also how many calories you burn with a given amount of exercise. That's all heritable. Sadly, how much exercise we choose to do does not appear to be a heritable trait. That seems to be a voluntary trait. Now, when we're looking at therapeutic strategies, what we do know is that people vary in their response to certain treatments, and it's been shown very clearly that the response to bariatric surgery, for example, is heritable. So when people happen to be related, their response in terms of how much weight they lose with a Roux-en-Y bypass surgery is very similar, as opposed to, for example, a husband and wife who might have completely different responses. So next slide. So when we're thinking about genes and affecting weight, the question is, what are those genes and where do they work? Well, actually, we've known for a long time that there's a key part of the brain involved in the regulation of weight, and that's the hypothalamus. And we know that because tumors of the hypothalamus were described in the early 1900s, and they caused weight gain, overeating, often infertility and sleep problems. And we know, of course, that the hypothalamus is really critical for regulating hormone release to the pituitary, but it also regulates appetite, weight, thermogenesis, and sleep. Next slide. And really the first clue about what are the genes, the pathways in the hypothalamus that do this, really only emerged in 1994. And that really shows you relatively recently, because certainly I didn't learn anything at medical school about the regulation of weight. This is all something that's emerged in the last 20 years. And the key discovery really was by Jeff Friedman and colleagues in New York, who found the cause of obesity in these mice. So you can see on the right hand of these scales, these severely obese OB mice. It's an inbred strain. They naturally become very obese. And these mice were found to be lacking a hormone leptin. And that hormone, when it was given back to the mice, corrected their obesity. Next slide. So now what we know is that leptin is made actually from adipose tissue. So our fat is there not just to store extra calories, but actually it releases hormones into the bloodstream, which then act in the brain and regulate weight, telling our brain about our nutrient availability. Now, the hypothalamus also receives signals from the gut, both neural signals and hormonal signals that tell us about fullness in relation to meals. And all of that information is integrated to regulate weight. And actually, for most people, weight remains relatively stable over time. And that's maintained by these neural circuits in the hypothalamus. And we know that because if you disrupt these circuits in mice, as shown on the left, you get obese mice. Next slide. So we really showed that this was relevant in people, going back 20 years ago now, when we studied children with severe obesity and found that they also could be lacking leptin. So the young boy on the left-hand panel was a child referred to us in the UK of Pakistani origin, consanguineous family, and we found that this child, despite severe obesity, weighing 42 kilos at the age of 3, had undetectable levels of leptin in the blood because he had a mutation in the gene encoding leptin. And so this was the first example of a single gene problem causing obesity, and also the first proof that leptin is important in regulating weight. Now, we knew that giving leptin back to the mice could correct their obesity. So we then started the first trial giving these children back leptin injections. And this is the same child 4 years later, shown on the right-hand panel, really with remarkable weight loss and now entirely normal weight. So leptin deficiency is a genetic condition, and the treatment of leptin deficiency has taught us that leptin is really important for control controlling weight. Now, on the right-hand image, you can see the pathway in the brain that is regulated by leptin. So leptin comes from our fat, acts in the hypothalamus, and it does a couple of things depending on the situation. So it can be the signal that after eating to tell you to stop eating after a meal. And the way it does that is that you release melanocortin peptides, MSH, which then bind to the melanocortin-4 receptor. You also have a separate sort of system that's part of this, which is telling you to eat if you're starving or if you're fasting, for example. And so we have pathways in the brain that tightly regulate our appetite, and those pathways are modulated by leptin. Next slide. What we showed is by studying many more children with severe obesity, recruited with the help of many colleagues around the country, and this is really one of the major strengths of the NHS, that we were able to lead this research with the help of many colleagues, is when we studied these other children with severe obesity, we found that many of them had genetic mutations in aspects of this pathway. Next slide. And we could see that several of the genes in that pathway, if they're defective, can cause severe obesity. Next slide. So what have we learned about leptin? Well, by treating these children, we learned that actually leptin has a major physiological role in terms of both the regulation of weight, but also in terms of the regulation of reproductive function. So these children without leptin will not go through puberty, but with leptin, we can send them into puberty at the appropriate developmental stage. Without leptin, they have impaired immunity, often get frequent infections, and in other countries, they tend to get very well, and sometimes there's some very high mortality associated with leptin deficiency. Next slide. Now, just moving on downstream of leptin, a key molecule and a key gene is the melanocortin-4 receptor. And this is important because it's the commonest genetic form of obesity. So we find mutations in our patients with severe obesity in 5% of patients. And actually, in a recent study we've done with colleagues in Bristol, we find that 1 in 300 adults in the UK have defective MC4R. So they have a mutation in this gene MC4R. There's more information on the website shown there. Now, when we bring in these patients, they all have severe obesity. What we find is the major problem is a disorder of appetite. So the children with both leptin and with MC4 will be constantly hungry, always wanting to eat food, and they'll be happy to eat any kind of food to satisfy their appetite. Even hospital food is very exciting for them, and that's clearly a disorder of appetite. So what we've learned is that these genes converge on these pathways, and they do so to regulate appetite. Next slide. Now, one of the other features in these children with MC4 is they're also quite tall, okay? And they also have quite an increase in lean mass, but otherwise they're quite well. They look quite big boned and quite solid. And so this is actually quite a common condition. This is 5 times more common than cystic fibrosis, for example, which is pretty unusual for a genetic disorder. Now, what we've learned, that's fine, next slide, is that these genes all map onto the brain and they regulate appetite, but also that we have quite an intricate system for regulating what we eat, because we have signals for hunger, for fullness. We also have signals related to visual cues about our food, to the fact that we like certain kinds of food or crave certain kinds of food, integrating smell and other information. And we and others are beginning to map out these regions of the brain. Now, why is this important? Because actually these are really fundamental systems that we have in terms of physiology. Next slide. And what we have learned from studies in mice, this is work of other colleagues, is that actually these neural circuits are highly conserved and they're really very acutely activated by food. So in this little cartoon, what we can see is people have developed interesting techniques for live recording of neurons in the brain. And if you do that, if you present a hungry mouse with food, you see immediate activation of the hunger neurons that light up, telling the mouse to go and look for food. And then if you trick the mouse and you give it sort of fake food, little wooden pellets, again, the hunger neurons light up. But as soon as it touches the food and realizes it's not food, that activation goes down. So we really have exquisite systems in the brain that will detect food, but also will tell us when we're hungry. And this is pretty fundamental for survival. Next slide. And really speaks to the fact that we've known for a long time. Next slide, please. Is that we have a set of highly conserved behaviors that will protect us and keep us from starving. And that's why we have these circuits for appetite and for weight, and why in the current environment, those circuits are really driving a tendency towards obesity. Next slide. And so the key thing really is that human appetite, which previously people tended to think was purely under voluntary control, it's all up to you. Well, actually, there is an innate or a hardwired component. There is, of course, an element that is under our control, that's environmentally induced, but it's the combination of the two that ultimately influences how we behave. Next slide. Now, another thing we learned from studying the patients with the MC4R mutations, this was the commonest gene for obesity, is that they had a relatively low blood pressure despite their severe obesity. In fact, the mean blood pressure was something like 120/68, which for people with a BMI of 45 is an unusually normal blood pressure. Now, what we found is that the patients had impaired sympathetic tone. I used to joke that I didn't really realize that was the issue. I used to think it was my great bedside manner. They're a very laid back group of patients. But what we qualified with the studies shown on the bottom left is that they had impaired sympathetic response measured using heart rate when we give them a strong stimulus. So what we found was that basically patients had impaired sympathetic tone, and that was the reason that they have a low blood pressure. Next slide. This was important because people were beginning to develop drugs that target MC4R, and Lilly had developed a compound that was very effective at weight loss, but unfortunately increased blood pressure. And so really this showed us that there's a strong link between MC4 and the hypothalamus, weight and blood pressure. Next slide. And this is just a sort of schematic of how that works and why it should be linked. So basically, leptin comes from fat. It then goes into the brain, into the hypothalamus. It activates this melanocortin circuit. Next slide. And by activating that circuit, you can, next slide, drive up blood pressure. And again. And what we find is that in patients who are lacking leptin, lacking the receptor or any part of this pathway, you don't get the increase in blood pressure despite obesity. Next slide. And what this shows us really is that the leptin melanocortin pathway is the system that links weight and blood pressure. So in common clinical practice, when patients gain weight, of course, their blood pressure tends to go up. When they lose weight, their blood pressure comes down. And the reason that this happens is the signaling through this pathway. So this is pretty important. Through the study of these unusual and rare patients, we've learned about a common pathway that affects most people with obesity. Next slide. So this is just a little illustration of how things evolve over time. So, when we first started looking at these genes, the mice had just been discovered. This is back in 1997. We identified the first patients in 1998. We then showed it was the commonest gene for obesity in 2003. Next slide. And then subsequently, the work was done to develop drugs targeting MC4R. The first line drugs did cause weight loss, but they increased blood pressure. Next slide. And now we have some drugs that actually seem to be able to cause weight loss, but without changing blood pressure. So we're very excited about the fact that we're finally now doing clinical trials, giving these drugs to our patients. Next slide. And again. And this is just a summary of some of the clinical trials to date. So we've got an MC4 agonist, so a drug that targets the MC4 receptor, and we've given it to patients who are completely lacking genes in this pathway with good effect. Next slide. We've recently completed the phase 3 trials in 2 genetic conditions, and actually it's been approved by the FDA in the US, and we're awaiting NICE approval. Hopefully we'll have a review in December of this year. Next slide. So what this means is we're finally being able to translate these scientific discoveries to bring benefits to patients. Now, we've been trying to see if we can understand more about other genes that might regulate weight, and some of the other approaches that we can take are going to be summarized on this slide. Next. So we focused mostly on finding rare genetic variants in people with severe obesity. Next. Now, a lot of people are looking at genome-wide association studies. That's quite a different way of looking at things. You're looking at the whole population, often thousands of people, regular people with spanning the whole weight spectrum. And if you do that, what you find are common genetic variants. And most of them have only a very small effect. They might mean that you are 3 kilos heavier than your neighbor over about 10 years. So very small effects. And if you add them up, then actually you're beginning to see why some people vary in their weight across the spectrum. Now, technology has clearly advanced in the last couple of years. And what that's allowed us to do is to capture more of the genetic variation that's there in the population. Next slide. And so in very recent work published in 2019, colleagues in the US showed that if you study UK Biobank, so that's a big volunteer resource of 500,000 people in the UK who gave their DNA and some clinical information, you can make a risk score which actually has 2 million variants put together. And that score predicts obesity. So in the black bars are the people who have the highest scores, and they're much more likely to be obese and severely obese. And so because we can now capture more of that genetic variation, we can have a better idea of who are the people who are most at risk of obesity. Next slide. And this is just a schematic illustrating how that actually relates to what's happening in the population. So effectively, you have a kind of normal distribution. There are, most of the people are in the middle. Some people have a low risk score. They're much less likely to gain weight over time. Some people have a high risk score. They're much more likely to gain weight. And then you can see in the kind of little cartoon is that the people with the high risk score by middle-aged weighed 13 kilos more than people with a low risk score. And those individuals had a higher risk of severe obesity. They tended to go on to have bariatric surgery. This has been sort of looked at retrospectively, and they also tended to have heart disease and higher mortality. So we're now being able to capture that genetic risk that we knew existed or we thought existed in the population. Next slide. And so another approach that we've recently been taking is to say, can we find other genes that could protect people from obesity? And we thought to do that, we wanted to look at people who are particularly thin. And by that, I mean a sort of BMI of 18, so really quite thin. But people who don't have eating disorders, who are healthy, don't have other medical conditions, but remain thin. And we all kind of know those individuals. They can kind of eat what they like and they don't put on weight. Very annoying. And what we're trying to do is see if we can identify those individuals and find the genes that are keeping them slim. Next slide. And this is just a first bit of data from that cohort. This is called the Stilts cohort. We worked with general practitioners across the country, really about 800 GP practices collaborated with us to recruit a cohort. We have now about 3,500 people who are thin but well. This is just the first bit of data from that. And what we found was, broadly speaking, two things. So when we looked for these common genetic variants, we found there appear to be specific variants that are keeping people thin. There are also variants that are associated with obesity. We knew that. And there are variants that seem to be regulating weight, where the score is higher in obese people and lower in thin people. And the right-hand panel, interesting, I think, shows a really important point, which is that when you do these risk scores for obesity, we found, of course, the risk score is higher in obese people, but actually it's very, very low in thin people. So people who are healthy and thin are thin because they have less of the genetic variants that we know predispose people to gaining weight. It's not because they're morally superior. And I think that's a pretty important point that we as physicians should understand and convey to patients. Next slide. And so another sort of strategy that we've taken to try to find mechanisms that might protect against obesity is, again, tapping into data from UK Biobank, this huge and valuable resource in the UK. And we focused on that gene that I was telling you about before, where we have the drug MC4R, and we characterized basically all the variants that were found in UK Biobank. Next slide. And what we did was we took the genetic variants and we modeled them in cells to see how they might affect the function of the protein. And we looked at different signaling pathways. Next slide. And what we found was that there's a whole spectrum of responses. So on the left, you see the kind of conventional signaling pathway. It generates cyclic AMP. On the right, you see a new pathway that we decided to study called beta-arrestin. And what we found is the changes, the variants in the gene in different people do different things. Some of them don't impact on its function, some of them impair its function, and some of them actually cause an overactive receptor, a gain of function. Next slide. And again, next slide. So we were really quite intrigued about the fact that there were some variants that were actually making the receptor work very well, a gain of function. Next slide. So here we then looked at the association between the different variants in people and their BMI. And what we found is that the loss of function variants, the ones that prevent the receptor from working, were associated with obesity. So that was kind of consistent with the work that we'd done before, where we found these mutations in our obese patients. But intriguingly, the gain of function variants, the ones that make the receptor work really well, or too well, actually were associated with protection from obesity. Next slide. And in fact, they were also associated with protection from type 2 diabetes. Next slide. And again. So next slide. And so what we found was that actually it was the signaling through the new pathway, the beta-arrestin pathway, that seemed to be the major link. And people, and it's about 6% of the population have this, who carry two of these genetic variants, have a 50% reduced risk of obesity and diabetes. So essentially you have one gene that plays a key role in regulating weight. That's its kind of major function. If that gene, if you have a variant in that gene that's not working, you're much more likely to be heavy. If you have a variant in that gene that makes it work too well, you're much more likely to be protected from obesity. And that really shows the strength of this genetic influence right across the weight spectrum. Next slide. And so we were trying to figure out, why do these variants offer protection from obesity? How come they lead to the receptor being switched on the whole time? Now, on the bottom left is just a schematic of what generally happens with a receptor. And what you find is that a receptor is on the surface of a cell, the hormone or the ligand comes and docks with it, binds to it, and then it's activated. For after about 10 minutes, it goes inside the cell, it switches off. And that's kind of the normal physiological system, because we don't want our receptors on all the time. Now, what happens with the particular change or the variant in the gene that keeps the receptor on is effectively it keeps it on the surface of the cell. So the receptor just stays there and keeps on working. Now, the job of MC4 is to tell us to not eat after a meal. So you can imagine, if your MC4 receptor stays switched on, effectively you keep on feeling full. You don't really want to eat. And that explains why you have a protection from obesity. Next slide. And so next slide, what we've been trying to do now is we're trying to work with a number of companies to see if we can develop drugs that target this same mechanism, effectively keeping MC4 switched on. And we know that that would be quite a safe thing to do, because the people who have this phenomenon actually are otherwise pretty well. They don't have any adverse effect of having a switched on MC4 receptor. Next slide. And again. So just really a little bit for the last little bit of the talk, to talk about new treatments that are coming up that I think are going to be more widely relevant for patients with obesity. And these treatments really tap into another bit of this physiological system that we have for regulating weight, and that is gut-derived peptides. So I talked to you about leptin and acting in the brain and in the hypothalamus, but we also have signals from the gut shown here, hormones that are released when nutrients enter the gut and signal to the brain, often to tell us about fullness or to stop eating. These peptides and these hormones also go to the pancreas and they release insulin, and that's called the incretin effect. Now, there are a number of drugs that have been developed that mimic that, and originally they were designed to treat diabetes. Next slide. And really a key peptide has been GLP-1, or glucagon-like peptide 1, which we know is a potent stimulator of insulin secretion. But interestingly, it also does many other things. It acts in the liver to regulate glucose production, and it acts on the brain to regulate food intake, satiety, and the palatability of food. And so what people found is, in the early trials giving drugs targeting this particular peptide, that actually you had knock-on effects on other systems, and particularly on appetite and weight. Next slide. So several different types of GLP-1 agonists have been developed. So there are receptor agonists, there are analogs, there are drugs that work in slightly different ways, but they all work to try to improve signaling through this receptor and through this system. And I think the beauty is that really fundamental insights into how the system works have now led to what is effectively a step change in the availability of medications for diabetes, and actually now also for obesity. Next slide. And so here is the data and some of the seminal papers reporting clinical trials giving liraglutide, a GLP-1 receptor agonist, to people with obesity and plus or minus diabetes. And you can see that really quite dramatic reductions in weight were seen in individuals. And they also improved HbA1c and cardiovascular mortality. Next slide. And it's really as a result of these trials that liraglutide has been recommended and is now in clinical practice, and as are a number of other drugs that will have the same mechanism of action. Next slide. But as I mentioned, really the exciting thing is that these drugs cause substantial weight loss. Okay? And so you get a kind of added benefit. So you get the effect of weight loss in terms of also improving diabetes, and then you get an effect of improvement in glycemia. And so here is really the data from semaglutide, which some of you, I'm sure, will have seen published earlier on this year. And really ongoing studies are looking very promising for this to be a major new therapy in the treatment of metabolic disease. Next slide. And this is also really of relevance to our patients with severe obesity and genetically characterized severe obesity, where now really we're entering a phase where we have a number of different treatments for our patients after many, many years. So at the very beginning, I told you about leptin. There's children with severe obesity. We've been treating them for 20 years now. They're doing very, very well, but it is a very rare condition. And finally, we do have leptin therapy licensed in the UK, and those patients are being treated. A number of companies are trying to develop other drugs that might work like leptin, so mimetics or sensitizers, not so much targeting those patients with severe obesity, but mainly thinking about the fact that leptin could be useful in other scenarios, and happy to discuss what those scenarios may be. But one particular area that leptin may be useful is in people who've already lost some weight. Because what happens when you lose some weight, of course, is that your leptin levels fall because you've got less fat. But that fall in leptin is a signal to the brain telling you to eat more. And that's kind of why when our patients lose weight and then they regain the weight, sometimes in the past we've been kind of guilty of, I think, telling them off and saying, well, you just didn't stick to your diet. Actually, that's normal physiology. When people lose weight, leptin falls. The fall in leptin is a signal to tell us to eat more and correct our weight. So that's the normal physiological response. And I think it would be helpful if we had strategies to try to help people with that weight regain. I mentioned setmelanotide, that's the MC4 agonist that we're giving in the phase 2 and 3 clinical trials. I mentioned we're hoping it'll be approved by NICE at the end of the year, but we're actually now running clinical trials in several other genetic obesity syndromes that all converge on the same pathway, and are really optimistic that we will be able to treat more patients with severe obesity. And the GLP-1 receptor agonists that I've just told you about do appear to be effective, of course, in common forms of obesity, but also in these severe genetic forms, and it seems that the pathway is almost like a separate pathway, and so it still works even if you have these other genetic disorders. And just a little bit of data on the right-hand side about bariatric surgery. Now, in many of these patients with the genetic forms of obesity, I would consider that bariatric surgery is contraindicated because, of course, you don't tackle the problem. The drive to eat remains. The hypothalamus is still sending those signals. And indeed, the few patients who have had bariatric surgery have tended not to respond very well. However, we do know that in the other conditions like MC4 deficiency, bariatric surgery can be effective. Here's some data actually in mice showing that if you lose one gene, if you're heterozygous, which is most people, it can work. So there are now sort of a number of treatment options for these patients, and that should be considered. Next slide. And really just a final slide about new therapies. I think we're very excited about a class of drugs called dual agonists, which are really emerging now through a series of studies. And really the lead compound is probably this one, tirzepatide from Lilly, who are running a series of trials called the Surpass trials, where this is a drug that's like liraglutide. It's an agonist for the GLP-1 receptor, but it's also an agonist from another closely related receptor called GIP. So you effectively get two signals for the price of one. And the kind of degree of weight loss that's being seen is between 10 to 15%. So really quite remarkable. They're now doing trials in obesity, in diabetes, in fatty liver disease, in cardiovascular disease. So I think there's pretty extensive plans to look at these drugs in a range of conditions. Next slide. So really just to wrap up, I hope I've shown you that severe obesity is a neurobehavioral disorder. It's really caused by disruption or impaired function of these hypothalamic circuits that are involved in the regulation of appetite. You know, the children who are lacking leptin were very driven to eat. They're constantly hungry. We give them leptin, we can reduce their appetite back to normal. The children with the MC4R mutations or with other genes in that pathway, very hyperphagic, very hungry. When we give them the new drug setmelanotide, they tell us they're no longer interested in food. They can leave it alone. They may only want one meal a day. So we can show that appetite has a biological control system. Clinical guidelines now recommend genetic testing, particularly where people are severely obese, but where the obesity started at a young age, particularly before the age of 5. And the patient may present as an adult, but it's really the age of onset obesity that's the biggest kind of clue. Next slide. And really these things are important. This is the clinical guidelines published in 2017. Genetic testing is now available in the NHS. Cambridge is the lead centre in the UK, but the testing can be organised anywhere. And it actually doesn't cost NHS trusts to organise the testing, but because it is a part of an NHS England initiative for genetic testing. So physicians, endocrinologists, geneticists can refer patients for this testing, particularly with these clinical features. Next slide. And really overall, I think the importance of these findings is for our patients, because I think we need to have a really clear understanding that genes, biology plays a major role in regulating weight in all of us. It's a strong effect in people with severe obesity, particularly people whose obesity started in childhood. And, you know, there's an awful lot of stigma faced by people with severe obesity. And I think that we as physicians have a responsibility to try to change that perception and deal with headlines such as this. This was actually, from many years ago now, headlines about a child who died at the age of 3 from obesity. In fact, there was so much media interest, the family had to move. And this actually child was a patient of mine who had a leptin receptor mutation and sadly died. That's a condition that we can now treat. Next slide. I just want to leave you with some thoughts as to why this is relevant for your practice. I think it's relevant for 3 reasons. You will only have a small number of patients that fall into the category that I've explained. However, genes and biology are relevant for all of us. And recognizing that genes play a major role in our weight and our biology plays a major role, we need to shift the conversation away from blaming people for their obesity and towards supporting people who struggle with their weight. This requires a bit of a change in the way that we think and the way that we approach things. But I think there's an analogy here with mental health, where we no longer blame people for having depression because we understand that it's a combination of a complex environment, social factors, and often some genetic tendencies that are contributing to that. And we need to understand the same is true for obesity. And we need to work hard, I think, to improve, to reduce the stigma faced by our patients. And that's really critical for the doctor-patient relationship. And actually, it's pretty clear that the likelihood of supporting patients is much greater if they trust their doctor, as it is for many conditions. I think there's an imperative to try to improve the lives of people with severe obesity who have the greatest health burden. It's clear that severe obesity is strongly driven by genetic factors, as I've shown you. Weight loss treatments finally now exist. They need to be more accessible, and we need to work hard to try and deliver on that. And clearly supporting patients to achieve weight loss is going to be good for their health. And then I think, you know, one part of it is to be on the lookout for patients who could benefit from some of these therapies, those with severe obesity that starts in early childhood. And key features might be patients from consanguineous families, those who have this incredible drive to eat and hyperphagia, where they're always looking for food. Some of the patients have developmental conditions and other clinical problems. Okay, next slide. I just want to finish really just by thanking you. Hope you found this interesting. Hope it can really bring a different perspective to how we think about what is a very common problem and which will be one of the major health problems of our time. Thank you.
Wow. Thank you very much indeed, Sarah. That's a quick trip around obesity from childhood to adult life. So about what, 2/3 of the British population is obese? How many of those do you reckon would have a gene defect?
So, you know, it's probably about, well, at least 1 in 300 have an MC4R defect. So that's very latest data from us studying a birth cohort, so unselected people. Now, we can't precisely answer the question that you've posed because the studies have been done in a way that's always a little bit selective. But it's at least 1 in 300 people have one gene, that's MC4, that's the commonest one. But basically across the population, it's quite clear that the people with severe obesity, which is probably about 5% of the people with obesity, will have a much stronger genetic burden. So, you know, these rare disorders are probably affecting about 1 in 300 people. But in the rest of the people, there's a higher genetic risk in the people with severe obesity.
Right, so there are lots of questions obviously on diet. So here's one which says, what is your view of low carbohydrate, medium stroke, high fat diets, LCHF, in the management of obesity, especially when associated with type 2 diabetes?
Yeah, so I think, you know, the data and the evidence suggests that broadly speaking, most diets are the same when studied in trials. It's really just the net caloric deficit, but there is a lot of variation. And of course, anecdotally, we all know that some patients may respond very well to one versus the other. And I think that there is a good rationale for low carbohydrate diets. Sometimes people are actually going a bit too low, particularly that's a bit risky in people with diabetes. But I think there is a reasonable rationale for low carbohydrate diets being effective. We generally think that across the board, they're probably as effective as others, but it may be that some patients find it easier to stick to a certain kind of diet rather than others. So at the moment, mechanistically, there's no reason to think that one should advocate one versus the other, but I think it's reasonable to support patients in trying different things to see which one might work for them.
Right, so of the 5% who are severely obese, do you think all of them should have their genetics done?
Yeah, so we're actually looking at that kind of question now. So in fact, in the next couple of days, we've got a consensus group to look at some of those questions. I think at the moment, the advice is, and I wrote those guidelines with colleagues, is that really only where the obesity starts at a young age. So that's a really good clinical clue, because actually in most people with obesity, it doesn't start at a young age. In most people with obesity, the weight gain is later in life, often after pregnancy or in middle age. So it's really about identifying the subgroup of people who've always been heavy as children.
And what's the sort of place of diet in those cases?
Yeah, well, I think, you know, it's complicated because they will have an increased drive to eat. So, you know, when you figure, you know, often what happens is we tend to think it's the patient is overeating and that's causing their obesity, which of course is ultimately what happens. But the reason they may be overeating is because they have a strong genetic tendency to overeat. And then, you know, the approach is okay, fine, of course, we tend to guide people and should continue to guide people to improve their diet. But we often find, A, it's very difficult, particularly for people who are less well off, but also it's hard to sustain. And I think it's about realizing that it's not just the simple solution is to say it's the patient's fault, pull yourself together, you should be able to sustain this diet. And I guess what I'm saying is just to recognize that actually it's much more complicated than that. People will have a bigger appetite, a bigger drive to eat. And the one bit I didn't really talk about, which is relevant for a lot of patients, of course, is the pathways by which stress affects eating. So, you know, we know a lot of people comfort eat, as we commonly call it. Stress affects the same neural pathways. So we and others can show that if you stress people out, you activate these same pathways in the brain. So the common responses that we see have a biological underpinning.
Yeah. In which directions? If you're stressed, are you going to eat more or less?
Well, it varies, of course. There's a whole spectrum. So the common aversion is, you know, stress makes people eat more because you eat something, it's rewarding. And you basically, we can show, we're using brain scans, that if you eat chocolate or you eat cake, you get a wonderful signal in the reward centers of the brain, the same as you do with alcohol or with other pleasurable things. You don't get that signal with broccoli. There are a few people who do, and they tend to be very thin. You know, comfort eating has a biological basis. It makes you feel good because it activates dopamine release in the brain. We can measure that, we can show that. And so people go back to it if they're stressed and if they're having a difficult time. So it's actually about understanding that the things that we see clinically have a biological basis. If we can help people to understand that and approach that, we may be able to help them to manage these responses.
Okay, so lots of questions coming in. So one is, what proportion of people with MC4R mutation are obese? 100%. And a follow-on to that is, to tackle morbid obesity, do we test for leptin deficiency or MRC4 mutation, or will that be introduced in the future?
Yeah, so not 100% of people with MC4 deficiency are obese. So most people are heavier. So what we did recently we followed up a birth cohort, and you see sort of from about age 8 to 10, the weight of people with an MC4 mutation starts to diverge. They start to become generally heavier from sort of childhood onwards. And they end up being about 10 kilos heavier as adults. So most people are heavier, and some will develop severe obesity. The factors that influence what happens, so for example, the severity of the mutation has an effect. So some people have a severe mutation that stops the receptor from working, almost invariably will become severely obese. If you have a milder mutation, that means a mutation that the receptor only works like 50%. Some of those individuals will become more obese, some may be overweight. And that will be modulated by what they eat, how much activity they do, and probably other genes. So there is a spectrum, and part of it is influenced by the severity of the genetic defect. And then the other question is about testing. So, I mean, leptin deficiency is very rare, and it's a recessive condition. So really, one is only really looking for that in patients who may be from a consanguineous family. MC4 is the common one. That's the one in 300. And the clues there really is the early onset again. So if your patient is severely obese and they were heavy as a child, and often patients say, you know, my weight matches my age. So I was 4 stone age 4, 10 stone age 10, 15 stone age 15. You know, so that's a kind of trajectory that we're talking about. So, and I think those patients who start gaining weight from a young age should be tested. And there's kind of discussion ongoing at the moment. It's not guidelines, and therefore I wouldn't recommend it in other groups, but we are discussing at the moment whether we should be, for example, testing patients who are going for bariatric surgery. What's the pickup rate? What would you find, and who would benefit? So that kind of thing. I think there will be some guidance on that within the next year or two.
So there's a couple of questions just on that saying, should all patients before bariatric surgery, obviously morbidly obese, have the testing done? And what is the place of surgery in the treatment of obesity generally? Yeah,
so maybe if I can answer the second bit first. So what is the place? I think bariatric surgery has a useful role to play in the treatment of severe obesity. I think in this country, we've generally tended to offer it to patients quite late, when they've had many, many years of severe obesity and are quite debilitated and often have many complications. I think in patients who struggle to lose weight through other means, and that's a large number of patients, it does have an important role to play. Now, should there be genetic testing? I think we're trying to figure that out right now. So there are a couple of studies ongoing that I think will help to address that question. I suspect the answer is probably yes, because 2 reasons. Firstly, if you find some genes, the patient may not benefit from surgery. And so you would put in the patient through a procedure that could be harmful, and we now know that. So I think that is one thing. And the second thing is, at the moment, then bariatric surgery was the only option we often had, but now with these new drugs, we will have other options. And so I think it may well be the case that we need to have a more stratified approach. There'll be some patients that benefit from surgery and some patients that benefit from drugs.
So how available are these drugs, and who should be prescribing them? Because I think there's so many people who are obese, they'll all be wanting them, won't they?
Yeah, so I think this also needs to change, and I think that clinical services need to change. In fact, we're going to be having those conversations with the politicians and with NICE fairly soon. So at the moment, it's really at the point of being approved, and it's mostly endocrinologists and weight management services that are treating patients for the obesity as opposed to diabetes. But of course, we've seen this transition over the last few years, that treatments that were only being given in hospitals for diabetes are now, of course, being given by colleagues in general practice. So I think this is going to change within the next couple of years.
Right. Another question here. Is there a risk that the new UK international trade treaties may inhibit the ability of the government to intervene in obesity prevention?
That's a complex one. I think obesity prevention is, the strategies for that are also being reviewed, and I suspect there may be some new initiatives on that front. I guess the answer is it's difficult to know. I think there are a lot of issues around the food environment that we have in the UK, the access to foods that people have, the cost of food, social deprivation, and therefore the options that are available for patients. So there's a whole complex societal and environmental conversation that really is important to that. I think the thing that I hope to interject into that is that there tends to be an assumption that it's down to the individual to fix things. And I think we have to take a much more nuanced approach to that. I think we have to recognize that we have to support the change in the environment, whether that's taxing high-fat foods to encourage a change in the composition of foods. I think, one of the things that I didn't really talk about is I mentioned the rewarding properties of food. That's the fact that, we know that high-fat food is highly rewarding. You put people in a scanner and you give them high-fat milkshake versus low-fat milkshake, even if you don't tell them, their brain can detect the fat content. So basically, our brains light up with high fat. And that's why a pizza is always going to be more interesting and appetizing than an apple. Okay. And so if that pizza is much cheaper than salad or vegetables or whatever, then you can, and it's more palatable, then you can see why somebody on a low income is going to eat pizza. So I think we have to understand the biology and how it plays into our behavior, and then see that actually we have to work on both things. So it's complicated, and I think that obesity policy perhaps has been a bit oversimplistic in the past.
Yeah, so certainly I think one's not going to tell somebody he's fat or she's fat and without holding back a bit. So lots more on dieting again. Is there any evidence about how or if dieting can lead to the derangement of your feedback loops governing appetite, fullness and weight?
Yeah, so that's a very good question. So what we do know is that dieting, caloric restriction of any form, so whether it's acute starvation dieting or a sustained diet, will cause a series of changes. And those changes are directly caused by the lack of leptin. So when we bring in students, medical students, and we do studies and we starve them for 2 days, we can basically mimic all the changes that you see in my leptin deficient patients. And then we refeed them, everything goes back to normal. Okay. So there is a physiological change that occurs when people are starved or lose weight. And those changes, the physiological response to those changes is to reset things and to overeat to restore energy balance. Okay. Now, what we don't know is what actually happens over time. Okay. What we do know is that when people have done a study in New York where they kept people in a unit for 6 months and they restricted their diet. And clearly when people lost weight, all of those changes occurred. And then what they found is that when they gave them back leptin therapeutically, they could basically help them to maintain the weight. Okay. So I think there is a lot of work to be done around basically realizing that physiology does change with weight loss. Okay. And one of the things that happens, and we've all seen it in patients, is that they may lose, if we can help people to lose some weight, often they then stagnate. Either they will rebound, that's a large number of people, or they may actually stagnate and not be able to lose more. And that's because you adapt to the weight loss and your energy expenditure changes. And so now you actually have to do more to lose the next lot of weight. So I think there's a lot of work to be done on understanding that physiology and then using that to try and better guide our patients.
It's almost like sort of resetting the balance, isn't it?
Absolutely.
Trying to do. So
and you have to actually work to overcome the physiological response that's trying to push you to restore things.
So should you sort of get them to lose weight first before you offer them any treatment?
I think the general rule of thumb is to guide people with dietary restriction. It is really all about diet at the beginning. Okay, so dietary restriction, and then that's a little bit about finding out what works for people. Of course, you know, for some people it's about the quantity of food. For some people it's about the type of food they're eating. Some specific diets will help some people versus others. The most effective means of weight loss for common forms of obesity is diet. And then once people have lost some weight, that's where physical activity and exercise tends to come in. Exercise is actually very poor at helping you to lose weight for most people. Helping you to maintain it, though, it is useful.
Right. So there's several questions here on the role of the general practitioner. As GPs, should we respond to, or what you've been saying, can we refer patients to someone if the BMI is over 40? At present, it's really difficult, and most will be on the bariatric workup, if anything. Who do we refer for genetic testing? And so, just to include, another one on GPs. No, I'll come back to that one.
So I think referring for genetic testing is really, again, severely obese patients. The clues are really the age of onset. If they were heavy as children, yes. If there's a strong family history of obesity or severe obesity, and particularly if there are other features, like, for example, consanguineous families, children with developmental delay and obesity, those are the groups at the moment. But really, also people who are very, very heavy. And genetic testing can be organized through both endocrinologists and geneticists and pediatricians. And then absolutely, there is an issue with access to services. There's an issue across the country. That is something that we and others are trying to change, because obviously now there are, as a wider range of therapies emerge, we need to have the services and the systems that will allow us to deliver those to the right patients. And it's going to be a combination approach, like with all conditions. There'll be things that happen in general practice that need to happen in a large number of people, and then there will be approaches that need to happen for people with the very severe obesity.
Somebody's asked about racial variations. So is there a racial variation in the incidence of MCO, the melanocortin 4 receptor?
So MC4R appears to be equally common in all groups. And they just seem to be different changes in certain populations, but it's equally common in all groups. It's heterozygous, it's dominantly inherited, so that's one reason. People from consanguineous families, sometimes you can see homozygous variants if they happen to have been married to cousins, and then conditions like leptin are recessively inherited. So those conditions we tend to only see in people from consanguineous families.
You said earlier sort of this was human stuff, but I look out the window. I mean, obviously not while you were talking, but when I look out of the window, I see the massive pigeons waddling. I mean, is there sort of a certain thing that's going on?
Sure, no, absolutely. And I think people talk about pets, and pets, the same is happening, obesity in pets. So yes, absolutely. So it's certainly happening in pets. There's certainly these genes are in animals. There are chickens with MC4 mutations. Those chickens tend to be bigger chickens. They've been bred by chance, and then they're found to have MC4 mutations. They make. I talked about lean mass, and the patients tend to be quite big. The chickens have a lot of lean mass. They're quite prized chickens. So there are chickens, there are pigs, there are a number of animals that were bred for size and meat. And those tended to, no one knew why there were the ones that were big, but then they went back and they realized they had MC4 mutations. And then actually very recently, a colleague of mine in Cambridge has shown that Labradors, which are often known for having a good appetite, and often probably one of the reasons that they're very good at being trained is that you often train dogs with food. You give them a reward. And actually, something like 40% of Labradors have a mutation in the POMC gene, which is the agonist for MC4. So they actually have a direct mutation in the same pathway. And that's often why Labradors get heavy and often why they're very hungry and have a good appetite.
Why
and
we
it may
see
explain why they're easier to train, because you could pretty much get them to do anything for food.
Yeah, I mean, any dog you see, any dog in a walker is always giving a treat.
Yeah.
Anyway,
exactly.
but we are seeing more obese animals as we are more obese humans.
Yeah.
So what's that? Is that just eating?
It is. So it is eating, and it's basically the fact that there's more availability. It's the same thing. There's more availability of food and the type of food, and we are basically set up to store calories. So genetically, humans and animals, it's a good thing to have a system to store calories because it protects you from starvation. So the system that we have is there to stop us from starving. And the problem is when we have plenty of food and we can access it easily, that system is maladaptive and it encourages us to gain weight. So that's kind of why we're seeing obesity. We're seeing it because of our environment, of course, but it's acting on a background where we are all genetically susceptible, apart from a subgroup of people who appear to be able to resist that and stay thin.
So this is really a follow-on question. So can we assume that genetic variance hasn't changed over the years, but it's just the availability of the calories?
So yes, that's right. So genetic variation hasn't changed, and it is availability of calories. It's the interaction between the two. So it's how you respond to the availability of calories is influenced by your genes. So some people will gain, a lot of weight. Some people will gain little weight. Some people will gain no weight. So absolutely, the epidemic of obesity is driven by our environment, but it's an environment that's acting on the genes, and the people that will become severely obese are the ones that have the greatest burden of certain genetic variants. If you like, the dice is loaded against them. So and then you add in the environment.
So there is a place for the diet then?
So there's always a place for the diet. And clearly, we're going to be advising people on a healthy diet and then actively intervening in people with diet. But I think it's about understanding that may not be very effective in some people.
Because of the genetics?
Absolutely.
Yeah. So in a sort of case of starvation, and I mean profound starvation, what's happening to your leptin and everything else?
Yeah.
Because what I want to come on to then is, when they do start feeding, has the refeeding syndrome got something to do with the genetics? Yeah,
so the refeeding syndrome is an interesting one. So it probably hasn't got to do with the genetics, but it has got everything to do with the same pathway. So effectively, when children are malnourished, severely malnourished, or and that could be from illness, that could be for any reason. Of course, leptin will fall. They will starve. They will have all the changes that we see actually in leptin deficiency, and then you also get an effect on arousal, on alertness. You get an endocrine effect for all of those things. And then when we refeed children and people, those changes can be reset. But what we don't understand is what happens with chronic malnutrition, for example, and what the sort of the actual refeeding syndrome does to those circuits. We actually don't know that yet.
Yes, but I mean, certainly we've had lots of precedences in the past with concentration camps, and that we don't know anything about what.
I mean, what we do know, obviously we don't know fully what. Well, we know that clearly leptin falls, and leptin then stays low if you continue to starve. What we don't know is, what else happens in the brain that changes and resets. And also, we don't know what happens in anorexia nervosa, for example. So in theory...
Yeah. So I was going to come on to that.
Yes.
What's happening there?
So in people with anorexia nervosa, they either with it starving or with excess activity, will have a low body weight. Their leptin levels are very low. And then actually, that's also why periods would stop in young women, because leptin is a link to the reproductive system. So leptin falls, the reproductive system shuts off. People did a very nice study in New York ballet dancers, where they then gave the ballet dancers leptin injections, and it restored their periods. And so it basically showed that they were still thin, but the leptin was the signal that was missing. Now, what I think is the interesting question is, leptin falling should trigger massive hyperphagia and drive to eat, telling you the system to eat more to restore the weight. So why does that not happen in anorexia nervosa, or what else happens that suppresses that? And I think that's something very interesting and important to study. Similar things happen in people with severe depression, who may have absolutely no interest in food and would lose weight. There should be a physiological response to restore the weight and overeat. But why does that not happen? And I think it's probably that higher brain centers can kind of override some of these things. And we see that in children who get infections. In everybody who gets an infection, of course, you often get a suppression of appetite. And then as your infection gets better, you often get very hungry and want to eat. People recognize that if their kids get sick, they don't want to eat anything. And then when the kids get better, they're ravenous. And that is because, the leptin signal is telling you to suddenly eat more and restore things. What's fascinating is that probably the cytokines that are released by infection can override those signals, because actually it's protective. If you're sick, you don't want to be eating something toxic. And there's another hormone that I haven't talked about called GDF15 that appears to be, it's only really been characterized in the last couple of years, that appears to be the signal to suppress appetite in response to toxic stimuli. And so this other hormone, GDF15, people are studying it and finding that it may explain, for example, chemotherapy-induced sickness. So chemotherapy is sensed by the brain as something toxic. And so you get nausea, vomiting, you suppress appetite. And this hormone is probably the signal that mediates that. So we're kind of, if you like, unraveling a whole lot of new physiology that explains things that we've seen clinically for some time.
We've got 2 minutes to go, but I've got 2 other questions. There are lots here, but just 2. In the assessment of patients, does girth or caliper measurement add much to our understanding? And do you share with me the impression that the difficulty UK patients seem to have in thinking in kilograms is a barrier to effective management? Whoa.
So I think calipers have no use whatsoever. I think weight is of course useful, weight and BMI. Waist circumference is useful. So waist circumference, waist to hip ratio, but waist circumference is sufficient, is a useful guide of central adiposity, which we know is an independent predictor of risk of type 2 diabetes, metabolic disease, cardiovascular complications. So, the BMI is useful surrogate marker of degree of adiposity. A waist measurement is also useful, and they both very tightly predict morbidity and mortality. Stones and kilos, I think that's an interesting one. Patients, pretty much all patients know what they weigh in, or will know their weight in stones, and hardly anyone knows it in kilos. I'm not sure that's a particular barrier. I think as long as we can juggle between the two and guide people, I think it's okay.
Okay. Well, I think last question, which is getting back to us and the patients. What is the single most important step that parents of teenage children should take to prevent their children going on to develop obesity in adulthood? And can I just add on, what is the most important step a GP can take?
So to prevent, I think the most important things to prevent are really to encourage people to have as healthy diet as possible, a balanced, healthy diet and regular physical activity. I mean, the things that we all know about. But I think to recognize that there are lots of reasons why people will struggle with that. And I think the single most important thing, if I could convey anything to my colleagues on this call, is really the doctor-patient relationship, like with any chronic condition. It's about, I think, if we can stop blaming our patients and be more understanding about obesity, which we still do it. We understand other conditions. We understand they may have problems with alcohol. We understand they may have problems with mental health. We need to understand why people may struggle with their weight. And it's complex, and it's biology plus environment. If we can do that, I think a single change in our attitude and our approach to patients can have a massive impact on the health of our patients.
You know, you just summarized your talk there. It really has been a fascinating walk through the mechanisms of obesity and hormones and how they interchange each other, and how really, in a way, we have got something we can do in terms of diet. Of course, exercise doesn't, I mean, you go to do a hell of a lot to reduce, get rid of a calorie or two, yeah. But it certainly makes you fit, I suppose, and may make you think that way around.
Yes.
So, Sana, thank you so much. I should call you really Professor Faruqi. Thank you so much for what you've given us. It's been a real delight to chat to you. And I'm sure, our listeners will have really gained a lot from it. So can I thank you for your time? Can I thank you for you and your research team for what you're doing? And many congratulations on your FRS.
Thank you very much, Maureen. It's a great pleasure to be here. And I hope you all enjoyed the talk, and look forward to staying in touch.
Thank you very much indeed.
Okay. Thank you. Okay.
Bye-bye.